warahmatullahi wabarakatuh. Good morning, everyone. First of all, truly, and all the time, it's a pleasure to be here in Al-Hasa. It's a very nice city. I liked it a lot. And also, truly, every year, I'm blessed with the quality and type of speakers and the topics that we discuss here, very unique. Emerging, re-emerging, it's a special thing and touch a lot of things in our brain. It moved our cells thinking about the cases with good, alhamdulillah, speakers and, and, uh, and challenging cases. So I'll go over Candida Auris, and I think the title our colleague here describe it as a perfect storm. It's something, again, special. Truly is causing huge storm in our healthcare institutions and moving silently for a while till COVID hit us, very hard and then become very obvious as an enemy in every hospital. I presented this before, tried to change it a little bit, but hopefully you'll find it very interesting. So I'll go over. I wish to have a mic. So we'll go over some introduction, then current epidemiology, and unfortunately, in the kingdom here, what was described in the literature, it's just outbreaks here and there. So we don't have like solid data about the epidemiology, especially if we want to go deep and impact and burden economically and also molecular epidemiology is not very strong. So most of what we have, it's just outbreak described here and there in different hospitals. Then I'll go over, early on experience in National Guard, how to manage our outbreak and number of cases in Riyadh. Some general recommendation from infection prevention control, as you know that I'm working in infection prevention control, and also then we'll end with conclusion. Generally, you can see here that the fungi itself or the yeast itself, it's very near to, from clade point of view, to close sisters and brothers that usually resistant, like Yersinia and Hemolani. So it's very close to them, and with that, it's very resistant. And early on, not now, early on, there was an issue with this identification, and this actually added a lot that we discovered it, unfortunately, in our hospital very late when things are out of control and it became burden. So early on, it was most of what we use in our hospital for identification were actually giving us false, species, and this, added. Now, almost all our hospitals, they have updated writing and also they have multi-token and other things. So it's not a problem anymore. 2009 in Japan, and then outbreaks here and there. We didn't, put it under the radar for a while, though that in literature, people, they start, saying that it's a problem. Till, 2016 when it hit, reaching United States, but you can see from 2009 to 2006, it becomes, almost worldwide. Four main clades, you can see here the South Africa, the South Asia, East Asia, and then South, America. But generally speaking, there are something about clonal distributions towards countries and regions. So every countries and every region, they have their own kind of sub, clade or part of genomic, specific things. So every region, they have their own. In the United States, they have almost two of them, and in the main area in the United States. And generally, the most prevalent one, it's in the India-Pakistan subclades. Starting in Japan in 2009, and now you can see that in 2019, it's almost worldwide. And now it's actually listed as one of the priority pathogens since 2015 first, and then 2019 the updated one. But now WHO considered to be Candida auris as a priority pathogen that can cause threat to our hospitals. You can see here, this is from 2013 to 2018 in the United States. How in every state they have an issue with either colonization or clinical cases, and it's going up and up, so it's trending up all the time. And we see this again in our hospital. This study coming from our colleague in the General Directorate in Infection Prevention and Control, where actually did this, retrospective study from 2020 to 2022, 45 hospitals, and this 45 hospitals, they actually collect 511, which is allocated as very small, kind of number, but generally speaking, they describe almost 85 outbreaks in these, 2 years. You can see the trends going up over time, and with this, underestimation, but generally speaking, the trend is going up. And you can see here that the most impact actually in the central region, the western region, the eastern province, the southern, the northern, and most of the cases discovered in the ICU because there are a lot of concentration when it comes to more sick patients and more transfer patients from hospital to hospital. So most of the cases are actually detected in the ICU. Resistant to a lot of things, and echinocandin considered to be the drug of choice most of the time, but all the time we are telling our colleague, don't just stop at, speciation of the yeast or candida, you have to go dig more to susceptibilities. Biting now is available in most of our hospitals, and the resistance to azote is very high. Purines, it will be around, 35%, reaching up to 60%, and echinocandin is usually around 7% resistant. 40% of them actually they have multi-drug resistant, and some of the species actually, some of the isolates usually they are, pan-resistant to all of them. So what are the risk factors? The risk factors going from old age, multiple healthcare exposures, antibiotic, antifungal exposures, indwelling bad devices, and also the comorbidity considered to be a risk factor. And COVID-19, maybe I mentioned that before, but COVID-19 added a lot to the problem, a lot. And you can see that after, COVID-19 pandemic, we can say after, but we are still living in the pandemic, it didn't go, at least from impact point of view, but we are still living that, time. But our colleague from India, in New Delhi, they're saying this is the, looking screw, which means that the monster under the bed, that we didn't see it. And they described like an outbreak, one of their ICUs where mortality among those who are infected with Candida auris reach up to 60%. So again, where is the problem, or where are the problems? The problem is actually very serious infection. It's called antifungal resistant. They have an issue with disinfectant, so it's not easily killed by current, disinfectant that we are using in our hospital. It can cause colonization. Colonization patient, they may stay for a long time, and also they are resistant in the environment. And it's almost the only candida that can, I think it's the only candida that can cause healthcare-related infections, can run from patient to patient. So most of the time, candida causing infection due to indigenous colonization, and then, going to causing infection patient. But Candida auris can go from person to person and transmit from person to person. The issue with that misidentification added to the problem early on, and we can't check late. And this is the problem again, and causing this, what our colleague here describing as a storm, because it's misidentified early on. So where did this live? It actually always came from where? From ears. But generally speaking, it's more in the salty area in the body. So we're looking to the axilla, the groin, and also the nose. So this is the mostly where this, candida, live. If you want to do some sort of screening, you have to consider this area. And those who colonize, they will have high risk of invasive infection. Those who colonize, they can transmit the infection to patients and to the environment easily. So everything in the hospital, and we did some sort of screening to our environment in the hospital, National Guard, and clearly we found that though some difficulty to isolate it from the environment, but in some rooms where we have patients with Candida auris, we isolated Candida auris from the environment. The first, highlight on the issues with sharing equipments from patient to patients came here in London, and actually what they are saying that they are using the armpit thermometer, and they use it from patient to patient. And what they actually found, they found that they have an outbreak of Candida auris where 40% of the people colonized and 9 of them died, and actually this ended by clear showing that there is transmission from patient to patient, and at the end they close this, ICU area. So the problem with sharing equipment, it's an issue for Candida auris. Not only the environment, but also equipment that we share from patient to patient, including the cuff for blood pressure and others. And you can see here that this is the strike one, it's the Candida auris. And when you compare to MRSA from log reductions with current used disinfectant, you can see that the hypochlorates contained disinfectant and hydrogen peroxide considered to be the highest to kill this bacteria. Other that we are using at home from all-purpose cleaners and also the quaternum ammonium, it's not good enough to kill this, and actually it's not effective most of the time. So all the time we ask people to go to the Environmental Protection Agency website and choose what type of disinfectant to use in the hospital. And we actually encouraged hospital to use more spirocidal agent now than the regular one. So highly, causing morbidity and mortality from literatures, well established, resistant to antifungals, well established, environmental resistance is well established, and also all of that adding a lot to outbreak in the hospital, and again it's well established now from data point of view. Bloodstream infection reach up to 50% of the cases, and mortality reach up to 60% of the cases. And this is now we're reaching to the experience that we have from National Guard. And this was actually published, a study by me and our colleague in National Guard and in Riyadh. And you can actually, what we did when we start hearing that we have Candida auris in the hospital, we start doing some sort of selective, prospective, active surveillance, and we do it mainly to characterize the presentation, the location of the hospital with higher risk, and where it's coming from, the community or from the hospital. And generally speaking, we find the cases, so any admitted patient to the ICU till now, we do this kind of screening, and also with patient transfer to the ICU, either from inside the hospital or outside the hospital, we just do this kind of screening. And if somebody is positive in the hospital, we actually do contact tracing, and not only for the patients, early on was patients plus healthcare providers, but now actually we stopped to just patients. What we are doing swab from the nose and also from the axilla and groin. So one swab from the nose, and one swab we do it from the axilla and also from the groin. So two swabs coming from every patient. And early on, as I said, we did the healthcare providers too. And we use the Vitig and Multitov in our hospital. So we use this, and according to the CDC recommendation from diagnosis point of view. And this is some of the measures that we use. We isolated the patient. We used the chlorhexidine medevac 2%. And as I said, that we did this, swabbing, and then we do reassessment every now and then, including the areas where positive involved. And we do this kind of test for every positive patient on a monthly basis to see when they are decolonized or clear. So we don't cohort a lot, but sometimes we have a problem with the number of single visits, so we cohort patients, and also we assign single patient item equipment all the time, and we use the sodium hypochlorite, and also we use hydrogen peroxide to clean and disinfect the rooms. So what we have from result point of view? From result point of view, you can see that we managed to decrease the trend up cases that we have, and it went down a little bit, and we're still struggling with the problem going up and down. We're using same kind of protocol till now, but generally speaking, we managed to show that it's an effective kind of interventions. Most of our patients, they were colonized. 23% of them were infection, and most of the cases coming from healthcare. So they acquired the infection inside the hospital, 18% only from the community, and most of them actually from the ICU, 32% from the ward. And the death rate, or you can say the fatality rate, reached up to 80%, and the 82% of them colonized or infected, they were alive. Most infection that we have, UTI and bloodstream infection, and most of the diseases associated with this: hypertension, diabetes, heart disease, renal disease, and lung disease, and neurological diseases. And you can see here that resistance is very high. So for fluconazole is and also voriconazole, flucytosine, itraconazole reaching up to 80%, and this is in our hospital, so different from hospital to hospital. Amphotericin around 55%, and you can see caspofungin actually is zero resistant. So the drug of choice was most of our patients is caspofungin, and later on we start to see now correctly resistant to caspofungin too. So this is where what are the antifungal that we are using, and we ended with this conclusion that colonization is high, and what we did is working, and healthcare-associated infections around 82%, ICU patients 68%. Most of the infections that we have is UTI, and then bloodstream infection, and our mortality issue up to 18% in our hospitals, and caspofungin were working, and we stopped healthcare worker screening because all our healthcare that we screened, they were actually negative. So we did the same, Nastral and also Candida. So we stopped doing, screening of healthcare workers. Internationally, they are also seeing the same things. This is one of the early studies. Micafungin was very susceptible if they're, isolate, and generally speaking, you can find them, they are good. And usually they acquire the infection within the hospital if they stay in the hospital longer. So if they stay in the hospital around 30 days, around 31 of the cases actually acquired in this duration, around 30 days. Within 7 days, 15% of the patient, they may have the problem if they are at risk. From where they got it mainly as a positivity from nares, groin, and also from the axilla. So this is where we should concentrate to do our screening most of the time. And here we are looking to the contact isolations. It could be indefinite, but usually it reach up to 2 months to be under isolation. So what we recommend from an infection control point of view, we recommend generally that we should isolate the patient, list to cohort, unless you have only if you have a problem in the bed. We dedicated equipment to all of them. We use API groups, biocidal, chlorine-based, and also hydrogen peroxide. We train our housekeepers on how to clean this rooms, and also we observe them all the time. So also we are doing for positive patients, we keep screening them if they stay in the hospital, and only we DC isolations if they have 2 negative, including the site of positivity before, and 1 week apart. We later on we keep them flagged in the system. Even if we de-isolate them, we keep them flagged in the system, and if they came to the hospital for another time, or come to the hospital another time, we do the test upon admission. There is no data on recommending decolonization with chlorhexidine, but generally we still using this action. And also we have a system to notify other hospitals in case of transferring patients. And usually we ask the other hospitals if they're transferring patient to us, if the patient is known to be colonized with Candida auris. So in conclusion, it's an emerging pathogen, highly resistant, associated with hospital outbreaks. It needs proactive management plan, including active surveillance and infection control interventions. And at the end, I will say, please be proactive, especially for Candida auris. And thank you very much. The next speaker will be presented by my colleague.
It's my pleasure to come to Habib. Rather colleague in our transplant initiative in Canada. He is the consultant adult disease and transplant infectious disease at King Abdulaziz Medical City in Western Region. His clinical expertise has been actively involved in medical education as an assistant professor in internal medicine and infectious disease in the College of Medicine, King Abdulaziz University. He is also program director of adult infectious disease fellowship. There, Dr. Hassan had his MBE from King Abdulaziz University of Jeddah. He had a contribution to research and academia with more than 15 publications, peer review, medical journal. And today he will share with us the insights about my course update.
your nice introduction. ثانيا أبغى أشكر صراحة هذه الكومنت في نص اليوم for the invitation, and I hope I will present something that's useful and interesting. So I will speak today about mucormycosis, update, diagnosis and management. So I remember Dr. Mustafa when he said consult ID. So I will start by this case. So I like this word, so I reintroduce it in my presentation. So this is an 18-year-old patient. So when I got the invitation, I think the same week or the week after, we have this consultation. 18-year-old admitted to the hospital with newly diagnosed as AML. So a patient, like December 2024, patient started on 7+3 chemotherapy, which is including cytarabine and anthracycline. Patient was on posaconazole tablet as a prophylaxis, as all we know in AML patient. So, we have been consulted because the patient has a new skin lesion in his right forearm. This is the lesion. So the lesion was started 8 days as a erythematous rash and then ulcerating. It became like blackish in color, surrounded by erythema, which is increasing in size. This is the first day when we saw him. This is the second day when we saw the patient. So patient started on, interesting, the patient was AFib, right? So patient started on bactam, vancomycin added, seen by dermatology. They decline as one of the differential local antibiotics and start broad spectrum antibiotic, and that's it. So I think this is the reason why you should consult ID for some cases. So when we saw the patient, including to or in addition to ecthyma gangrenosa, definitely fungal is one of the top differential diagnosis. Aspergillus mucormycosis should be ruled out. So biopsy is recommended. So patient has like neutropenia, and his platelet is almost 0, less than 10. So despite it's a skin biopsy, but we have like back and forth discussion and the need for biopsy. So this is one of the difficulties in NASADOR, AMM patient, neutropenic patient, thrombocytopenic patient. It's difficult sometimes to convince teams for even simple procedures. So we start him on liposomal amphotericin B, 5 milligram per kg, and then the biopsy came the second day, consistent with mucormycosis. So this is the objectives my topic today, microbiology and some clinical presentation and diagnosis, and some updates and management about mucormycosis. It's a disclaimer when I start to present mucor. The data is not like randomized control trials. There is no strong recommendation or data that supports one approach over the other. So see this beautiful picture? Very beautiful. But it's very high mortality, it's around 40 to 80%. And if you see the mortality globally, this is malaria, the yellow one is the mortality, tuberculosis, HIV, crypto, but when we go to mucormycosis, it reaches sometimes to 80%. Beautiful curve, but really bad outcome. So mucormycosis, as you all know, is life-threatening, as we said. It's mucormycosis or zygomycosis, back and forth like the name, but eventually mucormycosis is the name. And it's found in the soil and plants. It's angioinvasive. So when you see a necrosis, it invade the vessels and cause a necrosis. So this is the reason we saw like a blackish and discoloration. The worldwide species is Rhizobus, mucor. Epicete, this is the old name. For those who are interested in the mucormycosis, now is Leishmania. In Saudi, in a 66 retrospective review, Rhizobus was in 50% of patients. Mucor But when they use the DNA or DNA-based detection, apophysomesis, apophysomesis varialis. Variables, huh? Variables. So, they're difficult names. So, this is the distribution of mucormycosis. But this was in 2019. And if you see like Iran and Oman, they have like probably higher burden than the other countries. And some reviews in renal transplant patients from Iran, they have like 20% of mucormycosis. Saudi, but this is based I think on case report. There is not much publication at that time, but I think it's not real because multiple publication came later. 66 cases, there is a publication in the last 2-3 years. So it's a well known that rhizobus have a ketone reductase, more broth in diabetic patient, and commonly the rhinocerebral it's have been seen in patients with diabetes and DKA. Also, the iron overload and deferoxamine are also the really well-known risk factor. So the presentation sometimes it's correlated with the risk factor. So for rhinocerebral, it's the common risk factor is uncontrolled diabetes, and commonly seen with DKA patients. In one of the Indian review, like 70% of rhinocerebral mucormycosis have diabetes, and some of them they have DKA. While the hematological patient, they presented with pulmonary. However, the gastrointestinal seen in preterm babies with malnutrition. And this is cutaneous, commonly seen with trauma and burn. And we see it sometimes in neutropenic patients. So, COVID-19 and mucormycosis, though it's not really black fungus, but it was labeled in media as a black fungus, mainly in India, seen in diabetic patients and steroid. The rhinocerebral was the most reported presentation, and it was like interesting. When they did the case report study, they have like 1,733 cases of mucormycosis. They have like a huge cases and huge number of mucormycosis. And the overall mortality was in Indian, this case report study was 32%. This is one of the risk factors. I don't know how the zinc supplementation was correlated or as a risk factor. Renal transplantation, diabetes and DKA, and rural residents. So probably the area that they are living in sometimes as a risk factor for COVID. This is the presentation. It's really very aggressive presentation. The rhinocerebral, the common one, hyperglycemia and metabolic acidosis is the most common risk factor. Patients presented with acute sinusitis, fever, nasal congestion, purulent discharges, headache, and sinus pain. And spread like over few days, so early diagnosis is really important. And black escapation from the skin necrosis. This is the pulmonary, is fever with hemoptysis. A patient seen mainly in hematological, but less in diabetic patient. And also because the patient who has an voriconazole prophylaxis was labeled as a risk factor for mucormycosis. So a patient on voriconazole prophylaxis and he developed lung nodules, you have to think about mucormycosis. Again, this is in systematic review and we looked for breakthrough infection. Patient on voriconazole, they have a mucormycosis as a common pathogen for the presentations. While on posaconazole, aspergillus was the common, and fusarium was the common. So this is really the debatable one, is reverse Helosine. The reverse Helosine, you see ground glass opacities as inside and surrounded by consolidation. This is really very specific for mucor is not really, but it can be seen in 19% of patients with pulmonary mucor, and can be seen in 1% in Aspergillus. It's indicative probably of mucor, and there is one trial with Dr. Contiani. What they found multiple lung nodules, more than 10 nodules with sinusitis and pleural effusion. It favor of more of mucormycosis over the invasive pulmonary aspergillosis. Last week we saw a patient with reverse hallucine, but patient started on voriconazole initially and responding variable, and so it was like a nodules, and then follow-up images, very early images showed a reverse. It's not probably reverse hallucine, but the patient was responding variable and he was on voriconazole. So it's a very aggressive. This is the images in day 1, day 8, and this is day 15. See how aggressive this fungus is. Within 15 days, almost all the lung are wet. So this is one report. Pulmonary mucormycosis it's invading the diaphragm, and then it's invading the spleen, and probably there is some extension even to kidneys. This patient was reported that he has disseminated mucor or mucormycosis, and patient has partial or total resection of spleen, kidneys, colon, diaphragm, pancreas, abdominal wall, ribs, and liver. So it's very really aggressive infection. Mucormycosis in Saudi. We reviewed, we published our review in Jeddah, and I reviewed it with the report of Dr. Zain from Prince Sultan Medical City, and Dr. Abanoume. She did multi-center, including Tafassusi, King Abdulaziz Medical City, and Riyadh, and King Abdullah Medical City in Jeddah. So 15 cases in Jeddah, 18 cases in Prince Sultan, and 33 cases were multi-center. So it's risk factor a little bit different. In Jeddah, mainly oncology. Probably we have the biggest oncology center in Western region. While in Prince Sultan, the trauma was the most common underlying or precipitating factor. In this multi-center review, most of the patients were diabetic. So what the most common presentation is really cutaneous. If you review Jeddah and Riyadh and this multidisciplinary or multi-center study, it was cutaneous is the most common presentation. And the death is ranging from 29% to 73%. So diagnosis, it's the problem with mucormycosis is the diagnosis. There's no index suspicion, low awareness. So when we saw the patient, it was not like in a differential diagnosis or a type of differential diagnosis, and delaying of diagnosis definitely associated with significant mortality. No histology taken because bleeding risk, especially lung. Also, we think sometimes about aspergillosis rather than mucor. And fears of amphotericin. Sometimes even the patient on voriconazole or posaconazole has some possibilities. There is a fear of amphotericin, infusion-related reaction, chills, rigors, renal damage in patients with pre-existing renal function. Fungal cultures often no growth. So the fungal is really fragile, non-septated, and it needs special technique in microbiology to grow. So it's like 50% positive. Blood culture rarely positive, and positive culture definitely should be taken into consideration of the clinic. So mucormycosis does not have 3-week glucan assay and aspergillus galaxy. Sometimes can be a false positive, but it's sometimes if you we did everything, beta D glucan is negative, unlikely to be fungal. No, mucormycosis is still one of the candidates. Mucormycosis PCR. I don't know. Do we have a mucormycosis PCR in Saudi? Okay. Yeah, sequencing. So BL urine had been prescribed but is very limited, not available, lack of standardization. Multitop, some reports to using of multitop as well. Our patient, its histopathology shows broad, non-septated hyphae with a right angle, and this is one of the typical teaching slides for residents, fellows, how to differentiate between aspergillus and mucor. Aspergillus is thin, it's acute angle and septated, while the mucormycosis is aseptated, right angle, and the hyphae is wider. So treatment. Treatment, it's needed early diagnosis, early treatment, and surgery is really important. So in this paper by Dr. Quintani is a delay of 6 days. Only 6 days of treatment of mucormycosis is associated with twofold mortality. So if you delay it like probably 12 days, so you will increase mortality by 4 times. So it's extremely important to diagnose it and to start treatment early. Our case underwent excision of the lesions, but it was like a lot of issues and dilemmas. So patient on posaconazole prophylaxis. So why he has this lesion? Why on posaconazole prophylaxis? Unfortunately, we don't have a posaconazole level. Is the patient have like a therapeutic level for posaconazole? And the other thing is culture negative at that time, and probably we need susceptibility testing, which can be done in references lab, but really patient with posaconazole and he developed a fungal infection. Yeah, maybe it did not reach the therapeutic level. It was like day 9 or day 10 of posaconazole. But this is the question that it's raised all the time. So even if you start treatment or switch patient to azole's group, is azole's group can work in such patient? Is this really breakthrough infection? What's the treatment option? So the first line is liposomal amphotericin B. The dose is ranging from 5 to 10 milligram. And in a CNS, it was recommended by the European guidelines, which got published in 2021. It's to use a higher dose of 10 milligram per kg. So isavuconazole, it was approved by FDA. However, it was approved only on 21 or 22 cases. It's 21 patients, and it was compared to the historical data or historical cases. So eventually, it was approved for treatment of mucormycosis. Posaconazole has an activities in some literature mentioning MIC probably of posaconazole is less than isavuconazole. And there is a 2 formula available, oral suspension, which is not really recommended, and the delayed release tablet, which with high bioavailability, which is recommended. Also, posaconazole can induce pseudo-hyperaldosteronism. So sometimes you see like 10% of patients on posaconazole, they have hypertension and hypokalemia. So be aware about that. So this is the algorithm that's been published and proposed for European start liposomal amphotericin 5 to 10, for CNS 10. For SOT they recommend 10. And I think if you go to see the data about that, it's like very limited data, 6, 7 patients, and most of them they end with renal impairment. So be caution if using such doses. As recommended against is posaconazole suspension, which is the bioavailability is really poor. Liposomal amphotericin less than 5 milligram, and the conventional amphotericin, which is I think is not available in many of the hospitals. Okay. So you have to be aware about the QT intervals. Fluconazole does not cover. Itraconazole is not really recommended, but it has been used in India when they are like out of amphotericin or voriconazole. Isavuconazole and posaconazole. Interestingly, isavuconazole can sometimes cause shortening of the QT. So combination therapy, I had this slide last night. So I try to avoid this these areas with uncertainty, and there is no much data. And even the conferences, they are avoiding using like, or speaking about the combination. If you go to the guidelines, they are speaking about formulation of amphotericin with echinocandin, but this is based on 6 patients. They use lipid complex amphotericin with caspofungin, which showed success. I don't know how this success be implemented over the guidelines. Many studies showed combination, it does not work in 106 patients. And lastly, last year, they present all retrospective of using amphotericin plus posa and isavuconazole, which showed no much benefit. But this retrospective, they use combination of probably on more disseminated cases, so should be interpreted with caution. So the duration is you have neutropenia to be resolved, diabetes control, immunosuppression, resolution of symptoms, radiology should be responded. In isavuconazole, they use 84 days as a median to treat mucormycosis. But in reality and publication, it's ranging from days or weeks to even 3 years. Unfortunately, our patient did bone marrow, I think yesterday, and still relapsing AML, so probably he will be a very prolonged neutropenic. So this is a case, sometimes surgery is really fundamental and life-saving. In this case, he has like went into excessive debridement, eye excenteration, and multiple debridement to the base of his kidneys. And eventually this patient is survived when I see the literature. Pulmonary is very limited data on localized area. So the future is not really promising for mucormycosis. This is the new medication. Is not really that much effective in using on mucormycosis, especially mucormycosis. Some data of a combination. So this is the end. Mucormycosis, it's severe progressive fungal infection. Mortality is high, 73% in Saudi in our report. Rhinocerebral is the highest globally. While in Saudi we have more of cutaneous, probably is RTA, more road traffic accident that we had before. And definitely the delay of diagnosis and treatment associated with higher mortality. Thank you so much.